Hi, this is Dr. Kathryn Dao reporting for Room Now. I'm attending ACR 2021 Convergence, and it's been a spectacular opening. And I am so delighted to have with me today some of the key members of the Global Rheumatology Alliance. It's been very prolific in its research and been collecting patient data on COVID-19 that's been so instrumental in guiding us on how to manage our patients during the pandemic. So here we have Dr. Yazdany, Dr. Sparks, and Dr. Liew. Welcome to our program.
Thanks for having us.
Appreciate it. So could you distill for us, to our viewers, what you have discovered in the last year, now that a whole year has pushed forward compared to when we were about a year ago? And I'll just start with Dr. Sparks.
Wow, it's incredible, obviously, what the rapid pace that has transpired with COVID, and certainly the GRA, I think, has been ahead of the curve, particularly in rheumatology. So I think from the physician registry standpoint, which has been sort of the crown jewel of the GRA, I think it's been incredible as far as the number of cases, which obviously we wish we weren't in this position where the virus really got to this point where there were so many cases. But it has really broadened the scope and trying to really do very targeted analyses. So within the last year, certainly there was a major paper at the very beginning of the year related to both general factors and rheumatology specific factors and mortality among rheumatic patients, which really found, for our patients in particular, high disease activity, glucocorticoids above a certain threshold, certain medications, in particular rituximab, perhaps sulfasalazine. And then Zach Wallace and I, my compatriot, I feel like I'm his spokesperson at sometimes. So we did one of the first studies looking within a single disease, rheumatoid arthritis, to try to really understand whether the medications impacted the disease course, and really found a very striking association of rituximab use with poor outcomes, a relatively novel association with JAK inhibitors. So those are some of the things that come to mind, but certainly I want the other panelists to chime in as well.
Dr. Liew, what do you have to add?
Yeah, just going off of that. So that was the RA specific study. And then we have a vasculitis specific study that has been accepted that looks at a vasculitis population, including PMR, and what kind of factors associate poor outcomes in that group. And then we also have a lupus specific study that is being presented at this ACR and has been submitted for publication. And then we have some other studies all coming from the physician registry that are either in progress, currently being edited right now, or submitted. We just have so many more new things from this registry that we started just over a year and a half ago. So, and also other things that are not specifically related to our registry that came out of collaborations from our GRA group. And I think Dr. Yazdany could speak more towards that, especially the plenary that's going to happen given by Dr. Kim.
Absolutely. Yes, Dr. Yazdany, please add on.
Yeah. Well, I think one of the things that just has been amazing to watch over the last year is just how people have come together and collaborated on a scale that I certainly have never seen in my career, just rheumatologists all around the world contributing and also, actually reaching across specialties to combine data. That's been amazing. One of the papers that we worked on over this last year was actually combining data from the GRA with our inflammatory bowel disease colleagues and psoriasis colleagues who had a very similar registry. And one of the things we wondered is whether some of the things that we were seeing in the GRA would actually be similar to what they saw. And in fact, in all of the registry, people who are using TNF inhibitors were actually doing quite well compared to, other reference agents, like, for example, taking methotrexate or taking other combinations of medications. And it was really nice to be able to bring that reassurance back to the community that people using TNF inhibitors are doing really well. We've also been able to focus on health disparities. And I know that this has been on everybody's mind during the pandemic. We are seeing health disparities, not just in the United States, but around the world. And unfortunately, one of our papers just highlighted how striking they are in rheumatology. And really, that's just a call to action to all of our colleagues to go the extra mile to protect patients that are in vulnerable groups, whether it's through, counseling, increased vaccination efforts, or other things that we can do to prevent COVID-19.
Also add about some of the other initiatives beyond the physician registry, which has been really important over the last year. So I was privileged to team up with Julius Simard, as well as John Hausman, Emily Siratash, Jean, as well as Dr. Yazdany, Dr. Liew here. So we also did a new survey related to the perceptions and experience of the COVID vaccine among people with rheumatic diseases. So again, that's probably something that we thought of around this time last year, and we didn't even know that the vaccines were going to be efficacious at that point. And then we started to develop the survey and rolled it out, I think, in record time. And I think we translated it into almost 20 different languages. So to just see the amount of effort that went in, and we got a great response. We ended up giving over 11,000 responses from people with rheumatic diseases, and multiple papers are also coming out from that. I think other things to highlight would be a trainee survey. There's been trying to focus on the trainee experience for rheumatologists, as well as systematic reviews. A recent systematic review was really just accepted at A&R, which I think is really going to be the most comprehensive assessment for how COVID can affect rheumatology patients from a clinical perspective. So it's just really amazing how many people are involved, and we're all moving forward and trying to really understand this from every angle.
And I want to add, sorry.
Oh, go ahead. No, sorry. Go ahead, please.
And I want to add what Dr. Sparks has mentioned. Many of those things have either been presented at the annual meeting before or are going to be presented this year. For example, Kristen Young, who led the trainee survey, or was one of the leaders of the trainee survey, she'll be presenting an oral on like wellness and perceptions of the trainee experience during the height of the first peak of the pandemic. So that will be, I think, in one of the education sessions. And then the massive literature review that was actually a year-long project led by Evelyn Shea and Max Koenig and Richard Conway that just got accepted in A&R. That will be a poster that will be presented in one of the COVID sessions. So if you're interested, please look out for all of these things and give us a shout out, ask us questions, and just see just the different things that we have looked into over the past year.
Now, one of the things have been our patients are getting vaccinated, they're getting their booster. Has the GRA collected a lot of data on breakthrough cases after the booster?
Jean, you have to take that one.
I think the late breaker presented by Dr. Liew here.
So we have a late breaking abstract. It's L04. So this is a poster that will be presented on the last day of posters. And so your question is about breakthrough infections after the booster or third additional dose. And we don't have data on those such cases, but we do have data on breakthrough infections. So we looked at people who were fully vaccinated with a definition of 14 or more days out after the completion of the initial series. So like 2 doses of an mRNA vaccine or 1 of a Johnson & Johnson. So these fully vaccinated people, we had 87 of those. And then we also had a little over 100 who were partially vaccinated. So in the time frame, essentially between the first and the second dose. So it's a large case series that's from our registry. We made a call and asked people to enter these specific cases over the early part of this year up till September. And we really wanted to look at the people who are fully vaccinated and who got very sick and were hospitalized. So we have 22 of those. And I don't want to give any spoilers, but it really corroborates the data that we saw in laboratory-based studies where they were looking at surrogate markers for COVID-related outcomes, and how people who are on B-cell depleting therapies like rituximab or antimetabolites like mycophenolate had lower humoral responses, lower antibody responses to the vaccines. We're also seeing, unfortunately, patients on these therapies being frequently represented amongst hospitalized and fully vaccinated. So it really kind of reaffirms that message, and also leads us to say, like, what can we do in addition to vaccination, since everyone should get vaccinated? What can we do in addition to vaccination for these people who remain high risk for infection?
So one of the things that I'm always kind of curious about is what is some of the data that's not actually published, like that's not in the abstracts? Like, can you share with us some of the findings that you have that didn't quite make it into the abstracts for our viewers?
Well, one really cool project that we're working on, actually I'll show 2 projects. So the first one is trying to develop a clinical risk calculator so that, we can actually use some of the things that are readily available to us, like age, demographics, comorbidities, disease activity, and medications, to actually try to predict important clinical outcomes. And in this paper that we're working on, we're trying to predict ARDS, which is obviously, the most severe and common complication of COVID-19. And it was a very comprehensive project where we built a model using machine learning. We sort of validated it on a subset of the data, and then we validated even further in some external registries from several countries from around the world. And the model actually performed pretty well. And it's a very simple to use risk calculator that really just affirms the risk factors that have been identified over the last 20 months in people with rheumatic disease, things like age and comorbidities and prednisone dose and B-cell depleting therapy and disease activity. So hopefully that will be accepted soon and out there for people to use. The other thing is that one of the things that we haven't looked at previously, given our focus on sort of medications and clinical risk factors, is just what impact the environment and the region that people are from, and sort of the COVID policies in the community, what impact that has on people with rheumatic disease who might be immunocompromised and their outcomes. It's a very provocative analysis done by one of our graduate students, and really highlights that the disparities sometimes arise also from some of the community factors here in the United States, but also all around the world. So that's a preview of 2 things to come soon.
Very exciting. What about you, Jeff? What are you working on?
Well, related to the vaccination survey, we do have a paper published that looked at the clinical experience of the people who were vaccinated pretty early on. So that was really the people at the very beginning of the survey getting vaccinated in April and May. If you remember back to that time of optimism, and then, we definitely kept the survey open for the rest of the summer. So really the follow-up study is really trying to look at the entire perception around the COVID vaccine among rheumatic people. And certainly, just like the rest of society, there are some people who have reservations about getting the vaccination, people who are uncertain, some people who very clearly don't want to get it. So we do have a paper that will be looking in more detail about sort of perceptions. And certainly there's a lot of rheumatology specific things that are important to patients, in particular disease flare, in particular where their disease state is, the timing of their rituximab dose. So there's some things that are really, things we struggle with in clinic. So I think getting a big picture perception of this is going to be important. The other thing we're thinking about, and Jinoos, hopefully you'll agree we can move forward with this, is trying to understand the symptom and COVID disease course among people who develop COVID. I think we mostly focused on hard outcomes related to hospitalization and mortality, which are very important. But there are certainly a subsegment of patients that have very protracted COVID disease courses with the long hauler symptoms that may last weeks and months. And we think that there might be something special among rheumatic patients that deal with that, because they already have a chronic disease on top of that. So we'd like to at least get some descriptive studies to understand what is different about these people who end up having sort of, very long duration of symptoms compared to those who have a pretty quick and mild course.
Do we have any data on how many of our patients are long haulers?
We're really early in this analysis, and I'd say we don't want to go too far down the route of like rates and proportions, because this is a voluntary sort of survey and it's not a clear denominator. So we're trying to be very cautious in understanding some of the limitations of the GRA related to that. But I'm sure you've seen, just like in the general population, there's plenty of patients with rheumatic diseases who have a really long course that can be difficult. And another interesting thing related to rheumatic diseases is that particularly patients on rituximab might actually have a very protracted viremia compared to the general population, which might make this specific to rheumatology.
Right. What about you, Jean? What are you working on now?
So I am still working on the
Everything.
breakthrough. I am working on everything. So I'm working on the breakthrough infections paper. We've just submitted it and hoping to shepherd that through to publication. And I'm actually, what Jeff is just talking about is so hot. It's not even on the press because we are just in the very early stages of trying to figure out how we can address this question. So that's like the thing that I've been working on.
It's maybe too hot off the press. But,
We've been messaging about it on the Slack channel.
Today.
That's how, yes, today, a few hours ago during the meeting. So that's really what's next for us and for me.
That is so exciting. I am so glad that y'all are working on this. And, collaboration was one of the things that Jinoos was mentioning. And I don't know how y'all do it. I mean, collaborating between different registries, different countries, just different areas of medicine. What was the toughest thing that you have encountered when you were trying to collaborate with people? Is it just time zone or personalities?
I would say that it is the time zones. It's hard to schedule a meeting. We have a very narrow window in which we can accommodate our colleagues in Australia and New Zealand and Europe and, here on the West Coast. I mean, it's definitely a challenge. And some people have been amazing. Phil Robinson has to get up at a god awful hour in the morning in order to, be our fearless leader. So kudos to him and everybody that's been involved. I have to say that there have not been personality or other kinds of issues that I'm aware of. It's an incredibly collaborative and energized group of people. And I think that the sense of mission is just so powerful and overwhelming. Maybe the pandemic really just sort of highlights that sense of mission. And I think that has led everybody to collaborate and really to get along this whole time. I think we've been really lucky.
I think actually the biggest challenge, because we have so many people, and Jinoos always says it's a big tent, like everyone's welcome. It's when you have a project, you have so many people who are responding and giving you helpful comments on the manuscript. It's so amazing how many people are just really involved. It's not when we have these papers with so many authors, it's everyone's like provided a lot of input. They've provided their own cases. They've provided thought into what should go into the data presentation when we write the paper. And we've been joking, like Jeff and I, that it's like the problem of entering so many people and all their affiliations, because we've just got such a big team. But I wouldn't want there to be fewer people involved, and certainly wouldn't want to be more restrictive in who gets to work with us. I think anyone who has ideas and the time and the energy to help with our projects should be able to help.
I would definitely second the loading the submissions and dealing with the conflicts of interest. I think we've broken a few journal submission websites where they just couldn't handle that many authors in the past. So
yeah, even the ACR will let you have 50 and then you have to do something special. So it's been fun.
Can't wait till we're all in one place celebrating hopefully next year's ACR, that's for sure.
Yeah.
Probably with masks and socially distanced.
Well, thank you guys. I really appreciate your time that you took with me for this interview and, for informing our viewers what's going on. We are definitely going to continue to push forward, and hopefully we'll see each other in person next year. This is Dr. Kathryn Dao reporting for RheumNow. Follow us on Twitter, watch us on rheumnow.com. Thank you.